Good evening and welcome to the Insurance and Pharmaceuticals Subcommittee of the Health and Government Operations Committee. We appreciate your patience and understanding as we are in the part of session when we have to be extremely flexible and agile in our scheduling. And I appreciate everyone's time and patience as we move through bills. So we have 6 bills on our agenda for this evening. We are going to start with House Bill 333, Hospitals, Financial Assistance, Medical Bill Reimbursement Process. And Erin, would you explain what that bill does?
This bill modifies requirements related to a specified refund process for patients who paid for hospital services in calendar 2017 through 2021 and were eligible for free care. The bill alters the agencies with which the HSCRC must coordinate in the development of the refund process and the responsibilities of those agencies. It alters the refund process. It requires the Health Education Advocacy Unit in the Office of the Attorney General to assist patients in obtaining reimbursement. It requires hospitals to reimburse state agencies for costs incurred to implement the refund process. It authorizes tax information to be disclosed to a hospital, the HSCRC, and other state agencies involved with implementation of the refund process. It delays the due date for the 2024 HSCRC reporting requirement and requires implementation of option 3 from HSCRC's reporting December 2022 free hospital care refund process report. A reprint of the bill has been provided that incorporates amendments that were offered by Delegate Charkoudian, who is the bill sponsor. If you look on page 3 of the reprint after line 25, this requires the HSCRC, MDH, DHS, the Comptroller, MSDE, and hospitals to disclose to the Health Education and Advocacy Unit relevant information that is necessary for the unit to assist patients in obtaining reimbursement under the bill on receipt of the patient's executed authorization for release of medical information form that would be provided by the unit or other authorization form that is required by the Department of Human Services, the Office of the Comptroller, or the State Department of Education. And they would need to provide this information to the HEAU within 10 business days of the unit requesting that information. And then if you move on to page 5 of the reprint, after line 26, there's new language that provides that if a hospital fails to provide the refunds to the patients who qualify under the bill, the commission is authorized to impose a fine not exceeding $50,000 per violation. And in determining the amount of the fine to be imposed, the commission must consider the appropriateness of the fine in relation to the severity of the violation. The new language also provides that a violation of the section by the hospital is an unfair, abusive, or deceptive trade practice as defined under state law and is subject to enforcement and penalty provisions under state law.
Okay, thank you, Erin. Delegate Charkoudian, do you want to speak to the amendments?
I'm happy to. They are they for the most part came from the Attorney General's Health Advocacy Unit. They had played, I guess, a peripheral role, or maybe not at all, in the work group that had led to the creation of this bill as the solution. And so they just had some additional amendments after we had drafted them. And it's my understanding that all of the participants involved in all the stakeholders, the hospital association, all the advocacy groups are okay with the amendments.
Okay, thank you, Delegate. Is there now, Delegate Kaiser, do you want to speak to this bill? Okay.
I just have a really quick question because I was looking at the first paragraph, the fiscal note, and that of the bill, and I just want to confirm. I mean, with all the layers of all the amendments and all the technicalities and all the details, people paid for medical care that weren't supposed to, and we're just reimbursing them. Is that correct?
Yes,
that is correct.
Okay.
Sorry.
Okay. Very simple. Okay. Thank you.
Okay. Delegate Salega.
Thank you. Wondering about the $50,000 fine. Seems a little heavy-handed. Is there a reason that it's that much?
I'm gonna go to Mrs. Camarada. I think it was her amendment, right?
I'm here, Delegate.
Okay.
Yeah, that is actually the standard language in the Health General article and consistent with HSCRC's finding authority in general. So it's just that's their traditional finding authority, and that fine is not to exceed 50,000 per violation. And the commission is supposed to consider the appropriateness of the fine in relation to the severity of the violation. It's my understanding that HSCRC has not levied any fines for violations of financial assistance in the past. So that's just an up to number and consistent with what is already in the statute.
Does that
Just to follow up, please.
Sure.
Are trial attorneys going to get involved in this? And then it does move up to the 50,000? Or is this going to be adjudicated within the HSCRC or somewhere else?
I see heads nodding from someone from HSCRC. Megan Renfro, you want to respond to that?
So this is an administrative fine. It would occur from the agency. Trial attorneys have not historically been involved in the medical debt and financial assistance space. So I would be surprised if they entered into this space.
Okay, so this fine goes back to the HSCRC or it goes to the person who owed the money? Or
No,
the money is owed to?
No, I think it goes to the HSCRC, given that we have not imposed. Yeah.
Okay, thank you.
Yeah.
Delegate Bandari.
Thank you, Madam Chair. I'm looking the reprint of page 3, lines 16, 17, and 18. If reimbursement are provided incrementally and less than, it was 10%, now it is 5% of the estimated reimbursement. What is the rationale behind that? Could anybody explain that?
Delegate Charkoudian, you want to take that?
Sure, yeah, the bill that we passed last year, so we had started with a bill last year that we had, you might recall, that was very close to passing, and there were some technical pieces that we couldn't figure out by the time session was over, which is why it ended up with the HSCRC working on it over the interim. And what we had started with last year was 5%. So that had always been my intention. Somewhere in drafting or the report 10 ended up in here. And so I just put it back to where we had started the conversation last year with 5%.
Thank you.
And thus far, folks have not raised any objection to that. Is that right?
Correct.
Okay, great. Thank you. Anyone else want to speak to this bill? Do you have a motion on the amendments?
Move the motion.
Move the amendments. It's been a long day, Delegate.
It's late,
Do I
so.
have a second?
I'll second it.
Okay, I've got a motion and a second on the amendments. Is there any further discussion on the amendments? Seeing none. Will there be anyone voting against the amendments? Raise your virtual hand if you're going to vote against the amendments. Seeing none, the amendments
No,
pass. Oh, I'm sorry.
Delegate Collison, I just want to make sure we are discussing HB 333.
Yes,
Thank you.
yes. And
I'm
the
not-
amendments-
Yeah,
right.
I'm good.
Okay,
Then
I
I move the
saw-
bill as amended.
okay.
Second.
Fine.
I've got a motion and a second. Is there any discussion on HB 333 as amended? Seeing none, is there anyone who will be voting against the bill as amended?
I might
Okay.
change my mind later on, but
Okay,
I want to make sure I understand it a little bit better. Thank you.
okay. No, thank you. Anybody else? Okay, thank you. The bill passes. Thank you, Delegate Charkoudian and Aaron. You guys have a good evening, unless you want to stick around and talk more about insurance. Okay, we're going to move to HB 357, Pharmacy Benefit Managers, Definitions of Carrier, ERISA, and Purchaser. Delegate, no, not Delegate, Lisa, tell us about this bill.
House Bill 357 alters the definition of purchaser to include an insurer, nonprofit health service plan, or health maintenance organization. There is an exception made for Kaiser for purposes, and the definition is changed for purposes of state law governing PBMs. As a result, the bill generally applies provisions of law governing PBMs to all entities providing prescription drug coverage or benefits in the state, including programs subject to ERISA. There are amendments that are distributed that retain the definition of carrier and ERISA and retain current law for provisions of the bill that were flagged by MIA as potentially raising ERISA concerns.
Okay, Delegate Kipke, this one's your bill, right? Yes, you want to speak to this bill, please?
So we met with the Maryland Insurance Administration, a group of them. I don't know if any of them are on this work group right now.
They are.
Okay. See David Cooney, if anybody has questions, he's signed in. As you know, every time we've talked about this whole question about carrier versus purchaser is confusing. And so I had asked them to walk us through that and the reasons for it. And so they're here if you'd like to hear their explanation. The only area of existing state law that they thought might be in the gray relates to therapeutic interchange of treatments. So how the carriers try to switch things around, or the PBMs try to switch things around. Well, sometimes a union or an employer may make that decision on their own that they want a certain treatment. So it might interfere with the outcome of the Rutledge case and tinker with plan design. Although I contend that PBMs more often than not do it based on other reasons aside from plan design. But so basically the amendment before us just moves language around to ensure that we're in the clear as it relates to a legal challenge. I do know that Steve Weiner is here, and I think Brian Ho. I'm sorry, it's so hard to look at everybody at once. I don't know if they have any questions about it. It was me, Dennis Rasmussen, who sat down with the MIA. So that's where we are with it.
So if I could ask someone from the MIA to talk about how they would describe what the bill does now with these would do with these amendments. So I know Commissioner's on. I saw Mary Quay. I don't know if David Cooney is here. I need someone from the MIA to talk about their proposed amendments.
So David, do you want to take the lead on this, and I can follow up with any ERISA questions?
Sure, thank you. Thank you, Delegate. Yes, as Delegate Kipke just laid out, we had concerns because the bill as drafted, it placed certain definite obligations on the underlying plan, which in those situations could mean a self-funded ERISA plan. These are sections where the existing law specifically said carrier. So what we suggested is amending the bill so that those sections are still only applicable to a carrier. It doesn't change the fact that certain of those sections are still applicable to a PBM, regardless of if the PBM is acting on behalf of a carrier or a self-funded plan. But the items that specifically apply to a carrier, which would be the plan, those would still, under these amendments, would still only apply to a carrier to ensure there's no issue there. I will say though, unless I'm misreading it, we raised the therapeutic interchange issue, but I do not believe that this amendment actually addresses that issue. Lisa, could you clarify that for me?
Right. No, it does not. The amendment was drafted before that conversation, and there was some back and forth with Delegate Kipke about whether or not we could change that language to satisfy your concerns, but also to help other pharmacists a little bit. And Delegate Kipke, it's my understanding, right? You're okay with taking out conceptually, if we were to take out lines on page 13 of the bill, strike lines 14 through 20.
Yeah, it might be a bill for next year.
Okay, so if you have the reprint of it, we'd also be striking those lines on page 13 to address all of MIA's concerns.
So Lisa, so you're saying on page 13 of the bill, we would strike which lines?
14 through 20.
14 through 20. Okay. That's a separate. Okay. All right. So let me ask for some conversation before we move on any amendments. Anyone who wants to speak to this, to the amendments? Ms. Camarada.
Yeah, I actually just have a question. As opposed to striking what exists in the law that offers protections in therapeutic interchange space, why would we not just eliminate the carve out for PBMs? So eliminate lines, eliminate the brackets this bill imposes on lines 10 through 13 and maintain the protections that currently exist in Maryland law.
That's by striking that out, we're just retaining current law.
Okay, so it's my misunderstanding of what you were saying. Okay.
No, we're striking it out of the bill, so it won't and by doing that, we retain current law for the therapy.
Got it. My misunderstanding then, Lisa.
Yep.
Thank you.
Yep.
Okay. Mr. Johansson.
Good evening. On behalf of PCMA, we certainly still oppose the expansion of these provisions to not only formerly ERISA exempt plans, but apparently to other plans that are fully self-insured, such as government health plans, other than the state employees plan. We do think this is further, that's that second step of an unprecedented step that was taken a few years ago. And we just want to be on the record that we do oppose it. I believe you also have seen opposition not only from MACO, but Maryland Association of Boards of Ed, as well as employers such as in the Maryland Chamber who would be part of the formerly ERISA exempt plans. And just to clarify, Lisa, you would strike on page 13 lines 10 through 20, not 14 through 20, and that would fix the problem that was raised. Either that or you have to strike the brackets in 10 and 13, one or the other.
Right.
Can't get rid of 15-1633 unless you get.
Okay, so sorry. So
okay.
Bring that back in. Basically, striking the brackets. Okay. Mr. Hose.
Just to clarify, because there was an awful lot of confusion going on here. We made a mess of this part of the law when we split it all up with carrier and purchaser a couple of years ago. On page 8, there's a lot of strike through there, but by removing that from this, we're leaving it as it is existing in law now, correct? It looks like a double strike through to me, so I'm not quite
yes. Yes, so if you look at the function paragraphs on the first page, you can see they're struck out too. So we're retaining current law there. We're not making any changes to the law by striking it.
Double strike through, we're retaining current law as it is.
Yep.
Okay. Ms. Robinson.
Good afternoon, Madam Chair, members of the committee, Kimberly Robinson for Cigna. Like Mr. Johansson, we remain opposed to the bill. We think that the businesses who are going to be affected by this have no idea what's coming their way. And although the bill doesn't have a fiscal note because the law already applied to the state employees plan, it doesn't mean that it's without consequence to the businesses and governments, school boards and unions who are going to experience the changes that you're imposing here that are not part of what they're experiencing today. Specifically, though, I have a question, and I'll share that I did share it with Mr. Cooney prior to the call today. Section 15.16.11.1 seems to impact how one builds their pharmacy network, which to me does actually seem to be very clearly plan design, because PBMs don't design the networks. We provide the networks that the purchasers request. So if they say open access, it's open access. If they say they want a limited network, they get a limited network in the self-insured space. And this particular provision dictates how certain pharmacies can and cannot be in a network. So that did look like plan design to me, different than the other provisions, arguably. It didn't really click until I was rereading it just before the subcommittee. So I haven't had any substantive conversation on it, but I did want to raise that particular provision for consideration in the midst of my opposition to the proposal in full.
Thank you. Mr. Cooney, did you want to reply to that in terms of the impact of 15-1611?
Sure. I mean, I just essentially told Kim that, we did, EMI did our analysis of all the provisions, and that was not one that we identified as an area of concern in this section, but, certainly we'll listen to the discussion right here, but we did look at all the sections, and that was not one that we identified as an area of concern.
Okay, thank you. Mr. Weiner.
Hi there. Thank you for hearing me. A few things. One, I'm happy to hear for the first time from Kim that the other things in this bill do not affect plan design. I think it's the first time I've ever heard someone testify that not every dot and period and everything else is plan design. So that's refreshing. On page 7, 15.16.28. 15:16, I apologize. And this would be lines 25 through 27. So it's 15.1628, 25A, lines 25 through 27. The third line says shall disclose. So this section from 25 to 30 that has been stricken, actually 25 to 30, and then on the next page, bullet points 3 and 4, they appear to be disclosures. At the time of entering into a contract, it goes on and on and on. It says the PBM shall disclose to the pharmacy or pharmacist. And I don't understand how disclosure is design of the plan. Maybe Mr. Cooney can elaborate on that. And then again, Brian asked, and I apologize, I'm not an attorney, the strike-throughs that repeal the DIR section of Maryland law, which are the chargebacks, that they still apply to the previously affected individuals, correct?
Mr. Cooney?
Yes.
Yeah, to Mr. Weiner's first question, it's a little hard to see in the reprint with the strikeouts, but you're correct that section is generally talking about disclosures. But the issue here was when you get down a little bit farther in subsection A2, the amendments that were in the bill as proposed, it was going to strike a section where it talks about that a carrier or a pharmacy benefit manager may not do something, and it struck the word carrier, and it was now going to say the pharmacy benefit manager or purchaser may not require a pharmacy or pharmacist to renew credentialing more frequently than once every 3 years, or charge a pharmacy or pharmacist a fee for the initial credentialing or renewal credentialing. So at that point, the bill as originally drafted was actually saying that a self-funded plan may not require credentialing every 3 years or a fee. So it was actually placing an obligation on the self-funded plan.
But A1 could stay. The information part doesn't affect plan design, and that could stay, couldn't it?
Well, and it is, as Lisa was explaining, this section is just being stricken from the bill. So the existing law remains, and that part, as it already stands, is applicable to a PBM regardless of if they're operating on behalf of a carrier or a self-funded plan.
Okay, thank you for clarifying. I appreciate it.
Okay. Ms. January.
Thank you, Madam Chair. I just want to add a simple me too on behalf of counties to both Mr. Johansson's and Ms. Robinson's concerns regarding private plans. And I also have the go ahead to do the same for our friends over at MML. They're sorry that they could not join us tonight. We feel that private plans simply should be added to those exemptions at the bottom of page 4, going into page 5 of the reprint here. At least those offered by public entities like local governments and our local school boards. We're unique employers, much like the state, and it makes it much more challenging to offer really quality benefits for our staff. So we continue to struggle with the bill. Thank you.
Okay, thank you. Thanks for being here. Mr. Celentano.
Thank you, Madam Chair, for the opportunity. Just for the record, Matt Celentano, on behalf of the League of Life and Health Insurers, still opposed to this bill. And I think it's pretty clear the intent of this bill, we think, misses where the financial burden lands, and that's on the businesses that are trying to desperately design plan structures to cover their employees and save money on prescription drug prices that have been skyrocketing. And we think this bill, they will bear the burden of the price increases with this legislation. So we remain opposed.
Thank you. Mr. Leininger.
Thank you. Brett Leininger here on behalf of NAFA, Maryland, which is the National Association of Insurance and Financial Advisors. In opposition for the reasons discussed before, we're the ones, we're working with these plans to place coverage and have concern with the broad expansion of scope.
Okay, thank you. Mr. Kress.
Good evening. I appreciate the opportunity to comment. On behalf of the Maryland Association of Boards of Ed Insurance Programs and on behalf of the Laborers International Union, we would also be opposition to the expansion for all the reasons stated previously. So thank you.
Thank you. And a gentleman whose name is Consulting by JLG.
Thank you, Delegate Jeffrey Guido, on behalf of the Baltimore DC Metro Building Trades Council. We're opposed to the inclusion of the plans. All of our plans are self-funded. We negotiate those prices and the cost of those plans during our contract negotiations. And the increased cost to us takes money out of our pocket when we make that negotiation. So we are opposed to that. Thank you.
Thank you. Delegate Bandari.
Thank you, Madam Chair. This question is wondering to the opposition regarding the proposed changes to the definition. Is there any aspect that you and the proponents agree on or can find common ground on?
Asking me, Delegate?
To anybody who is like, is there any aspect that, these opposition and the proponent, you basically agree on, can find common ground on?
I would recall during the hearing, PCMA's person said that they were okay with certain things that we did in the past. Well, they've never been okay with any of it. And so they're never going to be okay with this. We've expanded all of these protections that are being expanded here. We've already done it in the state employees plan and to other markets, the individual market, the large group market. The sky hasn't fallen. And remember, I think some of these people who've been asked to come testify don't really understand what they're testifying to, especially the newcomers to this. Remember, the things that we've passed are things like make sure you have a reasonable audit, make sure you have a clear expectation of how you get reimbursed for your claims. We're not saying that you have to offer added benefits or anything like that. This is just a clear, we've really taken our time over the years to think through these things. And, but they fight hard against us every single time we do anything. So I wish we could have we did compromise on the therapeutic exchange. I personally believe that we could probably add language to get away with that, to not put ourselves up for a legal challenge in light of the Rutledge decision if the purchaser is actually the one making that decision and not the PBM, which it's largely made by the PBMs. So that was a pretty large concession on our part. And quite frankly, it's not, in my opinion, it's not great for the consumer when it's the PBM making that decision. So yeah, I wish we could get a consensus, but I don't think we ever would on this.
Thank you.
Mr.
Madam Chair.
Johansson. Yep.
Yeah, so thank you, and thanks for the question, Delegate Pandari, and Delegate Kipke, thank you for, your comments. There are things that hurt plan sponsors and plan design in this bill. The one that Kim mentioned on page 6, let's assume MIA says you can do it. What does this do? What this says is you can't create a plan design, which some of the school boards and counties have today, that says you can only get a 90-day supply through mail order or a narrow network. And if that narrow network happens to include pharmacies that are owned by the PBM, that cost containment measure will be prohibited effective January 1 of 2024, whether it's the middle of the contract year or not, whether it's the middle of the plan design year or not. If your plan starts on November 1, by the time you get to January 1, you've got to change that benefit package, and someone's going to pay more for it. Not the PBM, but the employees and the employer. So there are things in this bill, and we're going to have a discussion about audits. I think we would also argue that 2 years ago, if you now apply these plans to the elimination of the GER, which I think is part of this change in definition, some of the things that are already in law, then you can't do GER. And that certainly was an economic provision because the pharmacies didn't like it, but it was a tool that was used to level out payments for generic drugs. So I would just disagree. I don't disagree with the fact that you support what you support, Delegate. You know that. I would disagree with whether or not this has an impact. And certainly it is the first step into every other conversation on every other bill we're going to have. Is every one of these other pieces is going to be tried to expand to this group of plans that were formerly exempt. So I appreciate your comments, but I just respectfully disagree.
Okay, Mr. Weiner.
Yeah, so Delegate Kipke raised a very good point. We don't talk enough about the patient protections that are in these laws. A few years ago, Cigna, before it merged with Express Scripts, commonly would have pharmacies collect co-pays from patients for $50, and then they would capture that money back from the pharmacies, and the net payment to the pharmacy was $20. So understand, the members, the constituents, the people that had Cigna, which were mostly counties, their members would pay an inflated copay. The payer would claw that back from the pharmacies. It was a way of stealing from members and constituents. And pharmacy law as it stands now, except for self-funded plans, have fixed that. We can tell a patient, you could just pay $20 rather than paying $50 and having your plan steal $30 from you. So they're in fact, GERs. Let's talk about GERs because it was just brought up. You have a high deductible plan that's self-insured, and the member has to pay that high deductible upfront, and they pay a few $100s. And then 9 months later, the PBM captures back 80%. Why didn't the member pay that lower fee? Why did they pay the high deductible and then their plan stole the money back? They did it through the pharmacy, but when it's the deductible part, they're stealing from their clients. I would challenge that Mr. Initial Person, JG3, tell me what cost your members more money. Because they're really, well, regardless, there are patient and member protections. When we pass these pharmacy bills, more often when we protect small businesses that protect your constituents so they don't have to wait 40 minutes on the phone or 40 minutes in the store from the one pharmacy in the state that you can get a 90-day supply from, those things benefit your constituents if you value their time. Thank you. I won't say any more regarding this.
Okay, so let me recap where I think we are right now. and we will, then if someone has a response, then we're good. I mean, we'll move ahead. So what this bill does will open up the restrictions on some of the things that we have in our current law for only 17% of our market, 17 to 20%, I hear different wise, to the great big plans. And what those things are doing, that we are expanding to those bigger groups, are decreasing the number of options that plan designers have to save cost. This is an issue that has been settled by the Supreme Court. The Supreme Court said that, we have to look at what pharmacy benefit managers are doing. We need to, they don't say it in these words, but we need to create a level playing field so that everyone has the same, expectation and our state laws around the activities of PBMs. We've spent 3 years since that Supreme Court decision looking at what the impact would be, and I am adverse to litigation, and that's why we've put it off. But the MIA did a study last year in 22 that basically said there are some things that we can do to level this playing field. Now, I am not going to sit here and tell you that it won't have a financial impact, because it, as PCMA and the carriers have said, it will have to be calculated into these larger plans. But I can tell you that's why we're here at this point, and the bill you have in front of you is the bill that says, to the extent that our MIA and if they've consulted with the AG around the decision that the Supreme Court made, we think we are safe in making these changes. Okay, that's where we are. And I see Ms. Robinson's hand. Kim?
Thanks, Madam Chair. I'll be really quick. I just also wanted to share with the committee that the provision that Mr. Weiner just addressed, Dr. Weiner just addressed, one, we haven't had in a contract for at least the last 5 years and is federally prohibited here and everywhere else in the country. So that part of the bill is not a concern to us because it doesn't actually do anything to expand that, because the federal government has prohibited it everywhere. Although even when they did it, just about every company in the country had already abandoned the practice. So just wanted to make sure everybody understood where that was, since he decided to call me out specifically for something that happened, years before I came to the company.
Thank you, Kim. Delegate Taveras. Oh, you're on mute. You're on mute.
I want to thank you, Delegate Cullison, for summarizing that, because I've been clueless for like the last 15 minutes. But anyway, I want to make sure that I'm understanding. So this is something we must do because there has been a Supreme Court decision, and MIA took a review and saying these are the allowable changes. Now, I want to make sure I understand Mr. Steve Weiner's point of view, right? Because you're on the opposite side, or you're supporting this. I just want to make sure I understand where you're coming from.
He is supporting this bill. Yeah.
Okay.
Yeah, he benefits from this bill.
Okay, got it. Because I was questioning this whole idea on the scripts.
I'm sorry.
On the like when you have to, if you're using Cigna and you are being solicited to use scripts. And in some cases, that turns out to be more expensive than if you just went to the drug store every month. I just want to be able to understand where that falls in, that's no longer going to be allowed. Are they truly, before they truly used to say that scripts used to save them long-term costs? Is that what the PBMs used to say?
Can I clarify?
Yeah, Steve, you want to
Okay,
clarify that?
so as Kim mentioned, the practice, the example I used stopped, I don't exactly know, maybe 3 to 4 years ago, maybe 3 to 5 years ago. And it was a practice where we were collecting high copays from patients and the payer was capturing some of that money back. And at the time, we weren't allowed to tell our patients what was going on. That doesn't happen anymore, but it did happen. And we fought long and hard to be able to tell patients at the time what was happening because our contracts had gag clauses, which prevented us from disclosing any pricing information to patients from their pharmacy benefit manager. It doesn't happen now, but it was an example of how these laws that we fight long and hard to pass don't just benefit pharmacists, they benefit the patients that we serve. Mr. Johansson mentioned another cost-sharing mechanism that PBMs and payers use called generic effective rates. It's a little bit more complicated, but it's along the same lines where there is an initial payment to the pharmacy that is higher, and then later in the year, some of that payment is captured back. When that payment is all to the pharmacy by a payer, the pharmacy suffers. In the initial phase of insurance, when a patient has a high deductible and they're paying the first $1,200 before their plan pays a penny, if they're paying high and the payer captures money back later, it is the same situation where that patient should not have paid a high deductible. They should have paid the low amount right up front. So don't misunderstand that prohibition on that practice allows pharmacies to run their business and know what we're going to get paid and not worry about losing money 9 months later. But it also benefits our patients who pay a high deductible plan. These were just two examples of how the laws that we fought 3, 4, 5 years to pass every little sliver helps our patients and not just us.
Steve, those are
I hope that
those are respectfully.
Wait, Mike, wait. I'm going to go to Matt and then I'll come back to you. So, Matt.
Thank you, Madam Chair. Just for the record, Delegate Tavares, the court ruled what could be done, not what must be done. And there are states that do not share the MIA's view of the decision. And you're hearing from counties and businesses and plans alike that you're choosing to impact their concerns. And that's what's concerning to the carriers, especially at this point. Also, I don't appreciate, Mr. Weiner, you disparaging my colleague from Cigna's name who was not at the company. And that just seemed out of line to me. So I wish you would apologize, but
I didn't. I purposely said when I started that Express Scripts was not involved with Cigna when that practice occurred.
You've taken a couple swings at her, Steve.
Cigna did that practice. You should have a problem with them if you represent payers.
We're gonna move on.
Started it off by
right.
with it.
Okay.
I'm trying to mute myself. I'm sorry.
Mike.
These are really side issues. They're really unrelated to the bill, but I do think Mr. Weiner's opinions are personal opinions. We all have opinions. But the facts of whether or not certain things have benefited either individually consumers or plan members or plan sponsors, it's a really much more complicated conversation, which I'm happy to have offline.
Okay. So I need to ask a question. If we held this bill until next Tuesday, would we make any progress in finding some common ground on this bill? Mr. Weiner is shaking his head no. Ms. January.
My final comment on the bill, Madam Chair, from the local government perspective, we all know that it's hard to hire and retain right now. It's hard in our schools. My colleague from the local boards of education can attest to that. It's hard for our folks at the municipalities. It's hard at the county level. Unfortunately, what's going to happen if we pass this bill, particularly as reprinted, we as employers are going to have to pass along any additional costs, unfortunately, to our staff via their premiums, via their copays, whatever it might be. It's something that we would not want to do. It's something that we cannot afford to take on. I'm concerned with how that impacts hiring and retention. Right now, we're able to offer extremely effective and comprehensive benefits because we can't offer those salaries that the private sector can, but what we can offer are really great benefits to our folks. And unfortunately, this curbs our ability to do so.
Okay. Is there anyone else who wants to comment on my question?
Can I just get a review again from Mr. Guido, Jeff? Can you just restate what you said before, how it would hurt you?
What I said was we negotiate our costs, our medical costs. And every year every contract they go up. And we always have to take those negotiated wages, which would go going into our pocket or into our training, and put them towards the cost of the medical fund. You know, prescriptions go up, the chronic illnesses go up. We take a lot of steps and we spend millions of dollars a year to curb those costs, even in the point of establishing our own medical centers for our members to go to get their physicals and their prescription drugs, just to save money on those funds. Is that clear, or is there anything else you would like me to expand on?
You're supportive of Mako's position. That's all I want to be clear of.
Right.
That is correct.
Thank you.
Okay. Let me ask this question then, since I'm not hearing, I just don't see necessarily a resolution on this, but I'm going to ask, is there a motion on the amendments? Okay, hearing none. Oh, okay. Delegate Kipke has moved the amendments. Do I have a second?
Second.
All right, got a second. Any more discussion on the amendments? Okay. Those in favor of the amendments, or not in favor, will there be any opposition to the amendments? Okay, seeing none. Then can I have a motion on the bill as amended?
The bill is amended.
Okay.
Second.
Okay. Though, will there be anyone voting against the bill as amended? Seeing no hands, it is.
No.
Okay. Thank you. Thank you for that good discussion. Okay, we are now moving to House Bill 650. And Lisa, tell us what 650 does.
House Bill 650 specifies that carriers that provide coverage for prescription drugs may not prohibit a subscriber, member, or beneficiary from choosing a pharmacy or dispensary to obtain a covered specialty drug if the pharmacy or dispensary meets specified requirements. Likewise, a PBM that provides pharmacy benefit management services on behalf of a carrier may no longer require a beneficiary to use a specific pharmacy or entity for a specialty drug. And there was a markup that was distributed that I think Caitlin McDonough is here too.
Yes, I'm hoping she's gonna explain it to us.
I'm here, Madam Chair. Happy to.
Okay.
So Caitlin McDonough on behalf of Maryland Oncology and Hematology. Thank you, Madam Chair and Subcommittee for letting us discuss the bill. I think based on the hearing, some of the offline discussions with carriers and the PBMs. What we've tried to do with the amendments here is substantially narrow the bill to address circumstances where, and speaking for Maryland Oncology and Hematology, but I think this does impact other specialties as well. Specific scenarios with specialty drugs where patients are most impacted by delays and frequent dosage changes that cannot always be accounted for with specialty networks, particularly when they're mail order. So I'll run through the amendments really quickly. The first thing that you'll see is we had added the word dispensary to some of the current laws around, or the current statute around specialty pharmacy. We've been advised that a physician dispensing situation would already be covered. So we're just striking that for clarification. We've also stricken the language that would require a carrier to contract or allow a provider into their network, without kind of meeting network requirements, that any willing provider type language. What we do still have in the bill is with three very specific types of specialty bills, if a patient initiates the use of an out-of-network provider, there would still mandate coverage in those very specific situations. And those situations are, I'm sorry. If the specialty drugs are infused, I think it says infused, but infused or auto-injected, require complex dosing based on clinical presentation. And so those are scenarios where a patient may be showing up into a physician's office and based on their current clinical presentation, their surface area of their body, other kind of immediate clinical needs, their dosage may change, or medications that are provided in combination with other therapies, basically infusion therapies or radiation therapies. So again, a situation where a patient, if they don't necessarily have their current dosage or access to their medication that they have to take simultaneously with these other therapies, what happens now is they're put in a situation where they could either have it dispensed to them by their physician in real time, but it would not be covered. Get out of here. Or make the decision to wait and delay that coordinated care. Excuse me, not coordinated care, but co-therapy when you have an oral medication or a medication in combination with another therapy. So again, we're really trying to narrow it to the circumstances where, because of the way that some of these specialty networks work, particularly with mail order, that delay is particularly impactful for the patient. So that's what we tried to do here. And because of that, we also had to tweak some of the language around the PBM anti-steering requirements. So it basically maintains their ability to steer for specialty and mail order, except in these very specific circumstances that we've kind of outlined under the carrier section. So I'm sorry if that wasn't the clearest explanation, but happy to answer any questions. But we're really just trying to narrow it to these very specific situations.
Okay, so my goal on this bill this evening is to get an understanding of what these amendments would do. I'm not expecting to vote on it because folks haven't had enough time to look at it. So I am particularly interested in folks' thoughts on this. So I'm going to start with Ms. Rivkin.
Good evening, everyone.
Good evening.
Good evening. So, Caitlin, I'd love to have a conversation with you about this.
Yeah.
We haven't had an opportunity to do that.
I know, I'm trying, I'm running around.
I get it. And I'm glad, thank you, Madam Vice Chair, for allowing us to have some more time to talk, because I really truly believe what you've done here doesn't make the bill any better. And so we need to keep talking about it. So for example, just so, and I haven't had a lot of time to really go through it all, you kept, in bold language 2, which says an entity subject to this section may not prohibit a subscriber or a member from choosing a pharmacy that meets the terms and conditions. That's the same thing as what you did basically before. It basically opens it up to anybody who wants to meet terms and conditions, and the price can be in the network. And what I've said to you, so I think this goes further than just a very limited amount of circumstances. It still has any willing pharmacy language in here. And I still maintain that the law, this is absolutely unnecessary, because the law as it exists today allows pharmacies to request to come into the exclusive specialty pharmacy network if they meet the terms and conditions, and they can get credentialed as an exclusive specialty pharmacy, and they can meet the and they also accept the price. But first you got to do all the terms and conditions, and then we show you, here's the contract, or just like we do. Let me give you the example in employment. I can apply for a job and I don't just say, hey, I want to know the price, how much are you going to pay me? They've got to vet me. They've got to decide I'm worthy of the position. I interview with multiple people. They then offer me the job, and then they'll tell me what the salary is. That's not what you've done here. And so what you've done is blown up the whole ability for us to negotiate and have a contractual relationship, because it turns it on its head and says, if someone meets it, they're in. And we won't know that they meet it unless you have that ability to have that negotiation. So I have a real strong problem with number 2, especially because the law allows those to entertain the opportunity to join. I'm sorry, you want me to stop?
No, I just wanted to maybe one clarification. And again, I'm happy to talk it through, Deb, and I'm glad we're, because I'm working under a clock here and trying to draft it. I think the intent with number 2 is one of the things we're trying to be conscious of is that in the circumstance where someone might get this medication dispensed to them out of network, particularly in a physician dispensing experience, that it be triggered by the patient opting for that, not the physician. So the physician wouldn't be like, oh, hey, I can give it to you here. We would only do that in the circumstance where the patient has triggered. And that's what we've seen in other states. It's where they're really sensitive about that patient trigger. So we need to tighten that up. I understand, I see what you're saying, but like what I'm trying to get with the choice is they trigger it, not necessarily the physician.
We won't know that it's triggered, right? So,
okay. So again, we're just gathering information now. And so we'll hear from the other folks. And like I said, we'll spend a lot more hours. You guys are going to spend a lot more hours on it and come back to us on Tuesday. Matt.
It is very rare that I'm at a loss for words, but my friend Ms. Rifkin really explained a lot of our concerns. That the physician dispensing is still a major problem for us, and the any willing pharmacy and the dismantling of specialty pharmacy are still in these amendments. So I think that there's still a lot of work to do to get us anywhere, but extremely concerned and opposed.
Okay, thanks. Allison.
Thanks, Madam Vice Chair. I spoke with Caitlin about the bill and the patient care coordination specific concerns that that are being raised and where they're trying to narrow it. In those circumstances, KP is able to manage that. But since we have pharmacies and physicians in the same location, we don't have the same kind of care coordination concerns as others. So was requesting an exemption for group model HMO from this. And talked to Caitlin, and it seemed like they did not have a concern with that.
Okay, great. Mr. Worthing. You're on mute.
Hey, sorry to waste your precious moments here. Thank you, Madam Vice Chair. Angus Worthing, I'm a rheumatologist, I'm a physician, and we're responding to our patients' demands and needs here. I want to just clarify a couple of things that I've heard that are not necessarily the way I see it and the way my patients are telling me that things exist on the ground. About language regarding complying with regulations set by the state, where the intent here with the proposed changes to prevent physician dispensers or independent clinics from going through an application process to become a specialty pharmacy that might be burdensome or have hidden or unnecessary reasons to exclude us. This is advice from colleagues who are doing this in other states and running into barriers dispensing specialty drugs. So this is not out of the blue. This is some very practical language that we put in. A little bit about cost, and that hasn't come up tonight yet, but I hear about dismantling specialty networks. Specialty networks are really important for roughly half my patients. As an anecdote, I saw 20 patients today, and by the way, thank you for working at night so that I can take care of people during the day and talk to you at night. Maybe half the people do really well with getting their mail order drugs in a specialty network. They love it. They go to work, their medications arrive through the mail, et cetera. And the other half hate it. Just to be really clear with you, it doesn't work for them because of one reason or another. And usually it's phone tag and extra time that's unnecessarily spent. And I will say physician offices are forced to duplicate a lot of work. I'm checking, for example, for hepatitis or tuberculosis before starting certain medications, and then forced to prove that I've done that, which I wouldn't have to do if we could just dispense a drug. That would be duplicative. So there's this loophole for specialty drug and mail order drug in Maryland that forces people and their physicians or independent pharmacies to have all these patients go to specialty programs. And as I say, it works for some, doesn't work for others. This bill is meant to give people a choice, and I think we should give them that choice. Then finally, a little bit about cost. As you see in the bill this year, new language allows industry to set reimbursement. So it doesn't change the cost. There was mention in the hearing at the committee level about how this would change the ability for payers and PBMs to acquire price concessions, which doesn't change the price. It changes the rebate that is currently hidden, and it's possibly kept by the PBM, possibly kept by the payer. We don't know, except for in the Medicare system or public insurance system, how much is paid back to the purchaser or the patient. So I think that's a threat. I've seen that threat. We've all seen that threat before at other legislative bodies, at Congress, at HHS. I encourage you to recognize that for what it is. I'm happy to answer questions also, and I really appreciate the time that your committee gives to us, and on behalf of the roughly 30,000 people that my group takes care of in Maryland. Thanks.
Thank you, Doctor. So I have 4 hands. I'm going to take the 4 hands, and then we're going to move on from this bill, because again, folks just got this information today. We need some time to digest it, including me. So we're going to go with Mr. Shattuck.
Thank you, Madam Chair. I just wanted to respond to Ms. Rifkin's comment about number 2 and the current law, which allows for networks to bring in other specialty pharmacies. And I think, as Dr. Worthing was just saying, what we're really trying to achieve here is not elevate a physician dispenser to that of a specialty pharmacy, but to allow these physician dispensers the ability to treat their patients at the point of care. And as you heard from his example, maybe that's 50% of his patients. But if there can be a way to bring in that patient choice into this equation, I think that's where we're trying to find a path forward. We know that the carriers and the PBMs have their care coordination models. I think care coordination begins with the physician and the patient relationship. And if there has to be additional coordination with the pharmaceutical benefit side of things, then that's what we're trying to find a way forward. We're trying to take care of those patients that are going to be best served by getting their medicine directly from the physician without undue delay or additional stress. And as we've heard on this bill and other bills that have come before the committee, especially around utilization review, time is not always on the side of the patient. A setback is a setback, and it could be a setback that puts them in the hospital. It could be a flare-up that causes them to miss a lot of work or impact their social or their daily lives. So if we can find a way to make this bill work, I think that's what we're really trying to do. And again, it's putting the patient choice aspect front and center. We're not trying to upend the specialty pharmacy network. We understand, that's established and in place and it works. But we just want to get one more little tool for the patient and the physician to maintain continuity of care and make sure that everyone gets what they need in the best possible way. Thank you.
Okay, thanks, Dan. So it's late enough. Everybody's first name now, Kim.
Thank you, Madam Chair. I won't repeat, but I will endorse the comments Rifkin and Mr. Celentano made previously. And what I will add to that is that I think one of the complications in the bill is that it kind of takes the participation part of this backwards. We don't know what you're doing if you do it, if we're supposed to react after you've done it, right? So the patient chooses, and now you're supposed to come into the network, but we put you in the network first so that patients know who's participating and who's not in the network and what to anticipate. We can't know that you meet the terms and conditions beforehand, which means that you've put the patient now at financial risk because you are out of network when the service has occurred. And then if you decide you don't like the reimbursement or you can't meet the terms and conditions and you're now not in the network, how does that all work out? And so I think there's a fundamental challenge in how the bill is approaching that part of this in terms of what network participation means. I will say, speaking for me, I know that we've got some of these large specialty medical practices who have their own pharmacies. Some of them are owned by manufacturers. So they've got a pipeline into some of the drugs that they're using. And so we know that we have some of them, their pharmacies are in our network now. And so what I've never quite been clear on in the bill is the focus on physician dispensing, particularly when it comes from practices who own pharmacies that are also in carrier networks. I've not quite gotten my hands around what we're adding to, at least in that particular subset of what's happening here. Certainly, and I'll end on this, Madam Chair, as you heard from us at the hearing, setting aside the concept of markup on physician dispensing, which would still be a possibility if they're not in the network, right? It's one thing to say if they're in the network, they're taking the reimbursement. There's a whole nother thing that happens when it can be outside of the network. But we are always also concerned with the increased medical costs that come when our medical management programs that have been proven time over time to keep costs down for that patient because they're avoiding negative medical outcomes. And when they're not in those programs, people have greater outcomes. I think, ironically, we share Mr. Shattuck's position about trying to keep patients healthy, and knowing that we have programs that do that are absolutely undermined by the bill is why I think we still need to continue talking about it. And we look forward to that opportunity.
Okay, thanks. Dr. Ferozi.
Hi, thank you all, and thank you for allowing me to speak. I apologize because I was in the Zoom waiting room during the session and I wasn't able to get through. So I'll ask your forgiveness, but I wanted to seek some clarification because I did hear what was said. I just couldn't speak. Some things that I heard there that evening or that afternoon, which was interesting, which I'm hoping that our team can help me understand. I heard maintaining exclusivity maintains competitiveness. I'm just curious to understand what that means. I also heard reducing choice improves quality and lowers cost. I just want clarity how that makes sense. I'm not quite sure I understand. And increasing fragmentation improves efficiency. These are the things that I'm taking away from this, because why I'm saying this is because I'm in the trenches. I see what's happening. And a lot of things that are being said are postulations and what should happen theoretically, but I'm actually living it. This is a letter from a specialty pharmacy. I'll read it to you. This communication to inform you that we have made several attempts to contact the above patient to fill his or her temozolomide. They stopped, they couldn't do it. I got another one here. This is an email from a specialty pharmacy to my coordinator. We have made 3 attempts to contact the patient. On file, we cannot reach him. Okay, this is a drug I got just yesterday from a patient. We keep on talking about cost and outcomes. This is just, I'm sorry, for the people that are in your care coordination system, you might be having a good system, but for the patients that I'm taking care of that don't have access to a phone that works reliably, it's just ludicrous to think that your system's going to work for them. This is a drug, venetoclax, $16,000. I took the patient off of it. They came to me and said, I just got this last week from the pharmacy. What do I do now? This is a bag of drugs. Each box in here is $16,000 or $10,000 of drugs wasted because the PBM pharmacy keeps on delivering it and they don't realize that the patient has stopped her dose change. So I just want to bring everybody to reality on what's happening with patients, because there are some patients that it works for, but for my patients who have limited means and who are sometimes struggling because they have to work full time, it doesn't work. And why are we denying choice? I just don't get it. I'm very passionate about this and it really frustrates me. I'm getting tired of having interest get in the way of patient care.
I think we heard you. Thank you, Doctor. Sarah Price.
Thank you, Madam Chair. I'm with the Maryland Association of Chain Drug Stores, and I just wanted to note that we were supportive on this legislation due to our position that patients should be able to make their own decisions about where they want to pick up their drugs. So if there is any discussion pending about removing the willing pharmacy language, we would like to be a part of that. Thank you.
Okay, thanks. Matt?
Thank you, Madam Chair. I just say really quickly, I think you heard from Ms. Rifkin and Ms. Robinson about like real adherence numbers that carriers see when we have specialty. We know it works because we see the adherence go up. But I have to get back to about cost, because we talked about cost a lot this evening, and I'm sure we're going to continue to talk about cost in the prescription drug space for decades, if not longer. But one of our concerns with physician dispensing is the markup that physicians are taking on these drugs. We have the data from Medicare and Medicaid. The average markup for a single treatment, this is a single treatment, the average physician office markup, and I'm just going to give you a couple of different drugs. Herceptin, a cancer drug, the average markup by the physician is $1,800. Ocrevus, which is an MS drug, the average physician markup on a single dose is $4,400. I've got lists of these drugs from Medicare and Medicaid services. We think that the specialty network works. We know it's one of the ways we can use to control costs, and by giving physicians a chance to dispense, we're just going to see inflated high cost to consumers, and we're extremely concerned about it.
So, Matt, are those Maryland numbers, or are they?
These are national numbers.
They're national.
For places where physicians are allowed to dispense.
Can you clarify D or B?
Okay, we're going to
Is
go
that
to
Part B, Part D?
Yeah, that's wrong.
No,
That sounds
Medicare Part B physician
B.
spending.
So that this doesn't cover B.
But it doesn't matter. So
Yes, it does.
Doctor.
Yes, it does.
Yes, it does. Oh, it does? Okay. The problem is that your institution, US Oncology, is owned by a drug wholesaler, and you also have specialty pharmacies on the premises. You can literally have the patient walk down the hall and use the specialty network. To destroy the specialty network and just do nothing for the consumer but drive up cost.
Delegate Collison, may I respond to that,
Yeah,
please?
this is wrong.
Sure. Well, we're going to go to Allison, and she's actually going to have the final word before we move on to the next bill.
All right. Thank you, Delegate Collison. So I think there's a lot of misunderstandings related to Maryland law, especially Maryland Oncology Hematology, regulated spaces, and physician dispensing. So there are multiple regulations and laws in the state of Maryland related to physician dispensing. And I'll remind the committee that you've recently discussed physician dispensing related to Delegate Kerr's physician dispensing permit bill. So you do have a bit of a background in this, but I'll remind you again that physician dispensing permits, the permit that allows a physician to dispense medication in office, is tied to their medical license. A dispensing physician is only allowed to dispense medications that are within their realm of their specialty to prescribe to a patient that they are already treating, that they already have a relationship with. And they can only prescribe those specific medications to those patients that they're already treating. And that is tied to their medical license. Now, there are state regulations, and I have these regulations in front of me. These regulations are Board of Physicians Regulation 1032-23.06 and 1032-23.14. These prohibit a physician who is a dispensing physician from having any form of ownership right
in a pharmacy. It is illegal in the state of Maryland for a physician
Hold on,
to
Deb, I'm on the thing here.
it is legal in the state of Maryland for any physician to have any substantial ownership in a pharmacy. That is why there are separate regulations for dispensaries versus pharmacies. That is why we originally put dispensaries in the bill, because we thought we were clarifying something, but I apologize, we actually made it a lot more confusing. There is no medical practice that is owned by a physician in the state of Maryland that has a pharmacy on site, including Maryland Oncology Hematology, which is an independent physician-owned community oncology practice. The U.S. Oncology Network is a management service organization. We do the prior authorizations for the physicians. We have a client services contract, and my services as a state health policy expert is just part of that contract, in the same way that any lobbyist is contracted to their client. So it's true, the U.S. Oncology Network is owned by McKesson, and it's true, McKesson is a wholesaler, but that in no way means that McKesson has an ownership stake in MOH, and that in no way means that MOH has a specialty pharmacy down the hall with nefarious ownership. It's illegal. There is no practice in the state of Maryland that could have this ownership. And I think that this dilatory misinformation discussion is really sad, because what we should be talking about here is the patient, and the entire discussion that we came with today was kind of our heart in our hands saying that, and maybe we did a poor job of it, back to Deb's point, where when we went back to our bill and tried to edit out any willing provider, we did a poor job of it. But when we came here today, we took a huge risk saying we were considering editing out any willing provider, because right now we're in-network providers. And when we say that we care about our patients so much, that what we want to do is fight for them to be able to get these drugs in any possible way that they can at this point. And one of the most critical policies that has created this coalition, where literally every aspect of an organization of a healthcare interest in the state outside of carriers and PBMs has been in favor of this bill. And we've been bending over backwards to try and find a way to make it work for everyone. We're not trying to blow up care coordination. We're not trying to blow up a program that helps people. But what's important to understand is that the adherence numbers that you're seeing from insurance carriers relate to the patients that are enrolled in the programs. If a patient is not enrolled in the program, they're not included in that data. So they don't have data on patients who are experiencing harm. And when Dr. Ferozvi holds up this bag that says he's got $16,000 worth of wasted drugs, that's not included in the data that the care coordination program has of waste. So these are two data sets. We have a problem over here that's not being captured by the carriers that we're trying to solve. And we don't want to blow up the beautiful thing that they're doing over here. And I'm hoping we can come to an agreement here that helps. And I don't want to hurt anyone by blowing up your care coordination program. But the idea that we're wasting everyone's time by talking about MOH owning a specialty pharmacy is a waste of HGO's time as well. And I apologize for that.
Okay, we're gonna, I said you were gonna have the last word, Dan, she's gonna have the last word. So we have heard both sides, the committee's heard both sides, we have the amendments. We can, perhaps get a small group of us together to look at, some potential things, but this will come back to us on Tuesday. Okay. We're moving on to HB 374. Oh, no, I'm sorry. 382. Lisa, can you tell us what 382 does?
So there were amendments that were distributed on 382, which strike the bill. And Delegate Kippy had an amendment that would require MDH to study what MCOs pay for drug claims, what they paid for drug claims in calendar years 2021 and 2022, and what they would have paid if they had reimbursed at Medicaid fee-for-service rates. Delegate Collison, we talked, and there is another amendment that was distributed that includes some additional language to Delegate Kipke's amendment. That brings the Maryland Drug Affordability Board into the study and has them look at including how to address the inconsistency in the Medicaid, the two different ways that Medicaid pays for drugs, and to do that by considering the cost to the state. And the study would also require them to recommend a methodology for determining the ingredient cost and an appropriate dispensing fee.
Okay, thank you, Lisa. So what we're trying to do, I worked with Medicaid and to see, what we could do about the fiscal note. The fiscal note is too high. And I know there was a desire on the part of the pharmacist to be able to talk to the fiscal note writer and see if we could make that more reasonable. That's not possible, but this bill, these amendments will get us to that place. These amendments will say, all right, now we're going to really study how much it would cost to provide a reasonable ingredient cost and a dispensing fee. So I would ask if there are any questions. First of all, let me ask Delegate Kipke. Looking for you on the screen. Are you okay with the amendments that include your ask for the report on what the total cost was between the two variations of dispensing fees?
Like you, Chairman Cullison, I'd like to improve reimbursement now, but we've been told that without the blessing of the Appropriations Committee or the governor, we just don't have the authority to do that. However, this approach, I think, is sort of, I'm optimistic about the results that it might bring back and show a path to perhaps enacting the bill that was originally before us or something like it next year. Other states that have gone to the model that we've been suggesting have shown savings, and we can pass those savings along to the payer and also create a more reasonable reimbursement rate in Medicaid for the providers. So I support the amendments. Thank you.
Thank you, Delegate. All right, I'm going to go to Aaliyah Gordon.
Hi, was reviewing the amendments and talking to some stakeholders. And one of the questions was, in looking at the study, you're talking about seeing what the difference would be if we move to the NADAC and is it the NADAC and the fee for service dispensing fee, or just the fee for service dispensing fee?
Originally, the bill came in as NADAC plus 1067.
Okay, right. And the other question that we have is, we'd like to make sure the report also shows what the payment would be for what are PBMs getting out of what Medicaid is paying. So when the state is paying for these for prescription dispensing, that it's clear that it is what's actually going to the pharmacy.
That's, I think, what Delegate Kipke's amendment does. If you're asking for the amount that is kept by the PBM, I mean, we can talk about that, but I think that's going to be proprietary information.
Well, I was going to say, because when we look at what the drug spend is for the state, that's including the drug cost, the dispensing fee, and what the state pays for the PBM. So I think we need to make sure that that's differentiated. That's what I'm saying.
Oh yeah, no, that's what we're intending to do. There's two very different reimbursement numbers in Medicaid. So we want to get a handle on what the drug spend is in both of those settings, in both of those instances. And I think this will get us there. Sarah.
Thank you, Madam Chair. When we shared this with our members this afternoon, they also came back with similar questions that Aaliyah had. I think there's a bit of concern that maybe we won't be looking at the full scope of what the structural changes would be if the state did shift to a rate floor. So we were wondering if it would be possible to get a little bit of time to maybe share some additional parameters that could be included in the study.
We're all right, let me think about it let me hear what others have to say, and then I'll come back to that.
Thank you.
Ryan.
Moving around. Can you hear me?
Yeah.
Thank you, Dr. Carlson. I think we would be in support of the amendment. It says the total amount managed care organizations in the state paid pharmacies. So this would strictly be looking at what pharmacies were paid, would not take into account the PBM. My concern is similar to that of Aaliyah's, is that when we come back next year and we show that the pharmacies would be paid less under this model, we'll still end up with a fiscal note because the PBM piece would not be included in that. So, a lot of when some of these states have carved it out, they've brought it back into the fee-for-service model and eliminated the PBM. And some of that savings came from eliminating the PBM. So just to make sure that we're clear, it would be more complete and more transparent if the study also included what the PBM received as compensation in that package as well.
Okay. Mike.
Madam Chair, Mike Jansen for PCMA. I think spread pricing is completely prohibited in Medicaid.
Right.
So I don't understand where the additional revenue goes to the PBM. PBMs do charge administrative fees to their client, the individual MCOs. And the MCOs basically are subject to kind of rate setting within the Medicaid system. So I'm not sure you're going to find anything extra there, Brian.
It would just take into account those administrative fees. You would just see what those administrative fees were.
And what's the reason to see what our administrative fees are for providing things like drug utilization review, care coordination, the other types of things that we do?
Because the goal is to get at what the true cost to do this would be, and the true cost to do this would include those fees. It would not just be the reimbursement to the pharmacy.
So you want a study to show a shift to a fee-for-service dispensing model and what that would cost as compared to using PBMs?
As it would break it into the three pieces. So it would make it clear that it was this much to just pay the pharmacies on the fee-for-service model. Say if you carved it out, it would be this much to leave the current MCO structure as it is, pay the PBM fees, and set a reimbursement floor. And it would be this much to leave it as is and not do anything.
So this is a study of a potentially carve-out model.
Or a reimbursement floor.
And I would venture to say, when having MDH and the Prescription Drug Affordability Board study this, that we will get a lot of information. We're not going to get proprietary information. And I honestly believe that, that's in the contracts that the state has with the MCOs.
And we don't
right. Because the state pays the MCOs. It's the MCOs that are paying their PBMs. So I think, those two entities have a good database. And I know this because I've seen some data that the Prescription Drug Affordability Board has used. And I think that could be very informative to us when we look at this next year. Jim? You're on mute, Jim. Jim, you're on mute.
No, just on behalf of the independent pharmacies, I was trying to get an idea of what's the time frame that we're talking about for this study. The independents feel very strongly, and have for the last couple of years, and we've had legislation in on this, that the reimbursements are incredibly low. So what are we talking about in terms
The
of another
amendments,
study?
the amendments say that the study should be done by October 31st,
Right.
2020.
Right. So we'll have information at the end of October.
Okay, I have
Yep.
not had time today to look at the amendments, so I
Yeah.
apologize for that. The other thing is, I'd like to know, what will be the scope of this study? Or is it simply going to be limited to what has been proposed this year and prior years? Or is the study going to look at other options at other states, for example, West Virginia, New York, Kentucky, and others, I think Ohio maybe, other states have taken these carve-outs as another way to go. Is this study going to be comprehensive in terms of that?
I believe so, because I believe the Prescription Drug Affordability Board is already doing some of that, so we can ask them to include that in this. They're already looking at other districts and other states.
Okay, thank you.
Kathleen?
Madam Chair and members, I just wanted to be on the record. The MCO Association opposed the bill at the hearing. The bill has dramatically changed with this amendment. The association, we did our best to try and bring a position to you this evening. I'm not able to do that. There is some difference of opinion at this time, and I will likely will rely on individual MCOs to express their opinions to you about the amendments. But what I can tell you, and this touches on a concern that one of the other MCOs raised, or a couple MCOs raised earlier today, and I'm hearing it from the pharmacy lobby, that this bill seems to be a backdoor attempt at a carve-out. And the MCO Association believes very strongly in integrated care in the managed care program, because that is the best way that we can serve the whole person and provide the care and services in a coordinated fashion. So overall, if the study is necessary to understand better the financing in the program, but we would be concerned about possible carve out of pharmacy from the managed care program for those reasons stated.
And nothing would be happening this year. Everything would come back to us for us to look at next year. Okay. Deepak.
Thank you, Madam Chair. Same concern as Brian and Aaliyah. When I looked at the amendment, I was not sure if, like you said, there is proprietary information, but we want to compare the cost that the state is paying through the MCOs for these drugs, and then compare them to the FFS fee structure. If the PBM fee will be included in that amount because MCOs are paying a total, you're getting the total figure. Is that right? If I'm understanding it correctly?
Yes. So you're going to get the total spend from the state to the MCOs for the drug spend. So, and the MCOs are not doing the NADAC plus 1067.
Yeah.
So we will have that information.
And there won't be any carve out for expensive drugs that they'll be leaving out, so that
no, they're going to be looking at all of the at the drug spend, the state drug spend, basically, the Medicaid spend.
I think I'm confident that we'll show that there is too much inflation in there.
Steve.
Thank you.
I'd like to thank Chair, I don't even know the right title, Delegate Collison, but you're the chair of the subcommittee. I'd like to thank you for the amendment, and I'd like to thank Delegate Kipke for the amendment. I can tell you that Mount Vernon Pharmacy has no desire to get rid of the MCO mechanism. At least that hadn't occurred to me. I think as Deepak and Aaliyah and Jim have said, speed is of the essence. Pharmacies are struggling. I would say Baltimore City and Baltimore County, 5 pharmacies are closing. More than 1 are being opened. I can't talk to you about the rest of the state, but I can tell you about that. So speed is critical. And I would urge my pharmacy colleagues that have concerns, we can't do nothing for another year and get another $20 to $80 million fiscal note that can't move. This has to be reasonably determined. Now, I might have egg on my face next year. I don't know. All I can tell you is all the states surrounding Maryland have determined that paying this rate for everything has saved money. We might be some crazy island in the middle of surrounding states, but the states that surround us save money by paying this NADAC plus 1067. So the crucial part, it has to move in time for legislation for next year. It has to determine what the actual pharmacy were reimbursed under the old system and the new, which is what both of your proposed amendments do, and that I would support and recommend the committee supports. And then hopefully the pricing committee can determine some other things, or other things can be added. But those are absolutely crucial. And the thought is, without spread pricing, because that's illegal, as Mike Johansson said. So that's illegal. And I assume that's done properly. So thank
Steve,
you. I
thank you.
urge you to support the bill. I'll shut up. Thanks.
Delegate Taveras.
Y'all, it's getting late. I mean, I'm comfortable moving forward with the bill, with the amendments.
Are you moving the amendments?
I sure am, ma'am.
Okay. Do I have a second on the amendments?
Second.
Okay, I've got a motion and a second. Any discussion on the amendments? Brian, is your hand up to discuss the amendments? Okay, Kathleen, is your hand up to discuss the amendments? I know Steve just talked. Okay, seeing no discussion, those, will there be anyone voting against the amendments? Delegate Tavares, your hand is up. Are you voting against the amendments?
No, I'm ready to move the bill as amended.
That's right, you moved it already. Okay, oh, you're moving the bill. Okay, so seeing no opposition, it passes, the amendments pass unanimously. And Delegate Taveras is moving the bill as amended. Do I have a second? Okay. Any opposition to the bill as amended? Okay. Thank you. All right. So now we are going to the audit program. HB 374. And you've had a little more time with this reprint than the others. So I'm hoping that we can just work through it quickly. So you should have the reprint in front of you. And Lisa, why don't you tell us what the bill does quickly, and then we will go through the amendments.
So the bill expands the applicability of specified requirements governing pharmacy audits to all pharmacy benefit managers, including those used by Medicaid managed care organizations. The bill authorizes PBMs to conduct an audit through an auditing entity that is registered with the insurance commissioner, imposes additional requirements and restrictions on PBMs during the audit process, stipulates that PBMs or purchasers that they will have to pay specified fees to a pharmacy or pharmacist in connection with an audit, and it requires a audit report to contain specified information. It also authorizes the commissioner to adopt regulations. The amendments strike language requiring an auditing entity to register with MIA. They specify that a PBM conducting an invoice audit must accept as validation invoices issued no more than 30 days before the date of dispensing. They clarify that a PBM conducting an audit must accept a completed cash register transaction as proof of delivery or pickup unless there is contradictory information. The amendments also prohibit PBM from recouping funds or charging fees with regard to an incorrect day supply if the package size is unbreakable and the PBM cannot accept the day supply during the adjudication process. They specify a PBM may not have access to a pharmacy's bank credit card or depository statements of data as it relates to cost sharing. They specify a PBM cannot audit claims that were reversed or for which there was no nobody lost any money. Except if the audit is necessary to evaluate compliance to a contract, increases the number of prescriptions that may be audited from 50 to 125 and strikes language that would have required PBMs to pay pharmacies for audits. Additionally, the amendment strike language requiring final audits to include specified information on refunds and authorizing pharmacists to confirm receipt of certain refunds, and authorizes a PBM to use a secure portal in addition to a phone number to address audit-related questions, and requires auditing entities to provide a mechanism for secure electronic communications and documents submission during the audit process.
Okay. Now, for those of you who are hoping to vote on this bill tonight, we're not going to do that, but we are going to work through the amendments because I've heard that there are some that are still problematic, but let's work through them first and see where we get.
Delegate
question?
Yes.
Delegate Tavares?
Yes. Because this was a bill that we had already discussed this evening. Are we gonna get to 539 or 650?
We did 650 and I am gonna hold 539 tonight.
Thank you.
Okay, if we look at page 2 of the reprint, anybody have a problem with eliminating the fact that the entity must register with the commissioner, the auditing entity? Anybody have a problem with that? Brian, do you have a problem with it? Is that why your hand is up? Oh, you're on mute.
Sorry, the windows keep moving around. I would like to see that they are registered. We don't think that there's any oversight of these groups right now. They're kind of a wild card in the process. They're not under anyone's purview. So, you know, if someone's coming into the pharmacy and into the pharmacy area, they're gonna have access to pharmacy files. We'd really like them to have some oversight.
Mr. Cooney, are you still here?
Yes, I am, Madam Chair.
Okay. Can you speak to this?
Yes, I mean, essentially, for one thing, as it's drafted, just having them register with us doesn't really give them any oversight as it is. There's no authority for us to do anything with these entities under this bill as drafted. We also just do not believe it's necessary because even if there is any issue or problem with the underlying auditing entity, we could go after the PBM and enforce the requirements on the PBM. So this doesn't take away, or this wouldn't cause any issues with the pharmacies being subject to a auditing entity that wasn't complying with the law, because we could still hold the PBMs accountable.
Okay. Does that help?
Yep, absolutely.
Okay. Aaliyah, you have a problem with
I think he answered my question. I was going to ask is if you would go to the PBM, if there was an issue or complaint, would it go under their jurisdiction? And would they be?
The answer was yes.
Yeah.
Right. Okay. Looking at page 3. We changed line 12. We added no more than 30 days. Is everybody okay with that? Anybody have a problem? Let me ask this. Does anybody have a problem with that?
Can we get some clarification as to why that was put in? Our initial complaint here was that Caremark had made it so that these audits limited dispensing of products because of the fact that they were so restrictive as to the invoice. When the product is in date for 3 to 5 years, forcing us to have an invoice within 30 days, especially if it's a product ordered in for a specific customer, it may not be within 30 days. It could be 90 days out. It could be 100 days out. It could be a 500 count bottle. It could be a year out.
Can I have someone from
Good evening,
PBM?
Madam Chair. I'm happy to.
There we go. I was looking for you, Zach.
We suggested 30 days because if a unlimited time frame was allowed, we believe that could have a fraud potential or the potential to create fraud. We found that 30 days normally in the standards that we show that the average pharmacy turns over their inventory within 30 days. We thought it was a reasonable point, but we have a fraud concern with not having a finite date range.
Okay. Let me ask this, Brian, and Steve, can you live with the 30 days?
I don't think 30, the example that we gave when we testified was that we order a bottle of medication for a patient. It's a single patient. It's a 100-count bottle, which is the most common package size. They get a 30-day fill. We have 70 of those on the shelf, enough for 2 and a partial more fills. I think that if you're going to impose a date like our timeline like this, you have to make it at least 120 days to be able to clear a 100-count bottle for a single patient that you're doing to order for their health. So I understand that the unlimited may be a fraud risk, but none of these audits, I mean, all of these things say that, if fraud is involved, all this is out the window. So I just don't completely understand that.
Okay, Zach, can we go with 120 days?
I'll have to
And
check.
you have a
Sorry, I don't
time
know
frame.
if my colleagues would have.
Okay.
120 won't work.
Why won't it?
13 months will work. 100. There are medications that only come in 500 and 1,000 count bottles, and the CVS Caremark policy says we need to notify them before we purchase those bottles, and then it says they may or may not decide. So right now, what's happening today is I have generic Adderall in my pharmacy. I have it. In September, I bought a dozen bottles because it was going out of supply. I don't dispense it to Care First patients. I don't dispense it to Priority Partners patients. I don't dispense it to Part D Silver Script patients. I don't dispense it to AmeriGroup patients. I dispense that inventory to Express Scripts patients and to United Healthcare patients and to AARP patients. The 30 days makes me discriminate against my patient population and give inventory that I have that's in date. I can't dispense it. And if I do, the easy thing is when I'm audited, they'll charge back. The bad thing is the CVS around the corner from me will close me. If I dispense folic acid, cheap as dirt, comes in bottles of 1,000, I can't buy it in a bottle of 100. It's not sold that way. If they come in 2 months and audit that claim, they can kick me out of the network. So the 30 days prevents it makes me discriminate against my patients and not give medicine that I have in stock to any plan that's administered by CVS Caremark. 13 months is reasonable. And really there shouldn't be, it should be the way it was originally written. But
Okay.
our drugs expire in 2 to 5 years. 13 months, if you had to pick a number, is the only thing that has any sense in reality. It's not standard. United Healthcare and
Okay,
Express
Steve, you've
Scripts
made your
don't do it.
point. Steve,
Okay.
Deepak.
I second what Steve said initially. If there is suspicion of fraud, none of these laws apply. You are allowed to do whatever you want to investigate fraud. So now you're doing this to punish people or find ways to take back money. I don't think this is a fair thing for pharmacies because we do opportunity buys. They save us money and help us in combating lower reimbursements. Now you're taking that away. It doesn't make any sense for patient's sake, for pharmacy's sake, it doesn't make any business sense. Thank you.
Okay, all right. We know we're coming back on this, so let's continue. Let's look at line 22. We just said accept a cash register transaction as proof unless there's contradictory information. Can everybody live with that? Brian, your hand's up.
Sorry.
Can you live with this?
Yes.
Okay. Deepak, your hand's up. Can you live with it?
Apologies, sorry, I should lower my hand.
Okay.
Yeah, I'm good.
Okay. All right, we're moving to page 4. And on page 4, what we changed was lines 31 to 33. We checked with some folks because there was a belief. No, okay, and we think we covered the issue that was in 31 to 33 in what's new language under 3. So under, large Roman numeral 3. Can everyone live with that language? Okay, I'm not seeing any hands. That means it's, Deepak, you have a problem with the way number 3 is worded?
Not number 3, but I just want to give you an example of what happened in our pharmacy. CVS now charges us for sending an auditor to our pharmacy, because even if they find a silly mistake, it's a clerical mistake, they charge you $500 or some ridiculous fee. So I don't think that charge a pharmacy unless an audit finds there's always going to be some discrepancy they find. That doesn't mean we should pay, like, for a $3 drug, some clerical mistake, we're going to pay $5.
No, this says that it may not. That
Right.
you may not.
This speaks specifically to the cost of the drug, not a fee. So this is not incurring any penalty.
So line 23.
No, I'm looking at page 5.
Yes, but it directly speaks to page 4, line 23, that says a pharmacy benefit manager may not, and under 3 it says recoup any funds or charge any fees from a pharmacy or pharmacist, blah blah blah. Is that not where we are?
Well, I was looking at what's under line 4, and I think we're there on line 4. So let's go down to line 6 on page 5. As it relates to cost sharing, we added. Is everybody okay with that? Or can live with that, I guess is my question.
Yeah.
Right? Line 9 on page 5, except if necessary to evaluate compliance. Everybody okay with that? Okay. Cross out of line 17 to 20. Because we again, it's the charging.
Yeah, that was all the fees.
Right. Thanks, Lisa.
If I could make one quick comment on that. Those fees were an effort to sort of even the balances, because the risk reward of these audits. Again, I'm not really aware of any pharmacies in Maryland that have been removed from a network because of fraud. Maybe there are. I'm pretty active. I haven't heard any. So I see audits that are mechanisms to capture funds. The one point I'm making is, yes, you're going to get rid of all the fees to the pharmacists. You're now tipping that risk reward back. In return, think about on the next page, instead of 125 prescriptions, think about meeting in the middle at 75 or 80, because you have eliminated that risk for the PBM. They're still going to pay a low-paid employee to take up valuable time of a pharmacist. So I'm done, but I think about that when we go to the next one.
Okay, so I've got Aaliyah and Deepak and Kim. Aaliyah? And we're talking about lines 17 to 20.
Madam Chair, someone has their mic open. It's really hard to hear because they're creating a lot of background noise. I don't know who.
Mike, is that you?
Probably not.
Whoever it is muted. They've muted.
Okay. Okay, great.
Mine
Okay,
was on the 125, so I'll wait.
okay. Deepak?
I apologize. What Steve said is tipping the balance here, and that's why I thought page 3, line 31 to 30, page 4, line 31 to 33 relate to that. Like, we should not also be charged any fees if they find any discrepancies. I mean, this is part of their administrative costs. They're sending auditors because they are charging administrative fee to these insurers. So why are we being charged fees on top again for sending patients? If we are canceling these fees to the PBM, then we should cancel the fees to the pharmacy too.
I think that, like I said, in the conversations that I had with MIA and other representatives of pharmacists, we said that we were trying to meet that goal with the new language. I'm moving on to lines 7. We did 17 to 20. Now we want to talk about the number. So we've had all the way from 50 to 250. 125 was the compromise number. And so where are we going with 125? Aaliyah?
Well, that was my question. Where did the 125 come from? It does seem still a bit high.
Okay,
now
and Zach's going to tell us why. Zach?
Yeah, we would contend it's not high enough, actually. We would contend that 250, which follows most states that have these types of audit laws on the books, 250 would be a more appropriate number. There's a statistical validity point to this as well, which we feel would be comfortable with 250, but we recognize and appreciate the compromise figure.
Okay, so in other words, you can live with it. You'll choke, but you can live with it. Is that what I'm hearing?
I'm just
Your
trying,
words, not mine.
Yeah.
can I just try to understand when he says that? Are you saying that you're taking a statistic random sample, or what are you trying to explain by that?
All of these claims are a statistic sample. So the 125 figure on a desk audit, that would be 125 random claims. We would contend that 250 is a better number.
And Delegate Tavares, please raise your hand because I've got people waiting to speak.
I'm sorry. I apologize.
Okay, Steve.
I think because you've taken away all of the risk by taking away 17 to 20, I would lower that number to 75. As someone who gets audited more than most, maybe whatever. I just do. They're not statistical random samples. They are expensive, heavy weighted samples where if there is something missing, the recoupment is tremendous. So they're not random. They're high and they do take up a lot of time. And I would drop that a little bit, but if that's not doable, with all the other compromises, if this would move, I would support it.
Thank you, Steve. Kim?
Zach shared what I was going to share, which is the predominant number in states that have, in fact, legislated it is 250. The only thing I would add is, given that this bill is now expanding to significantly more businesses with varying volumes, varying programs and different needs, who typically put audit requirements in their contracts with those providing their benefits, this bill is already going to create challenges for them about what they're typically seeing and what they're typically having access to. So I understand why the compromise was what it was, Madam Chair. I think that we were okay with the 125. We do think it was low, looking at it through the lens of all of the prescriptions for Baltimore County government. I think creates a different challenge than it was before, but I don't even know what to offer where that is concerned for how this is going to disrupt this for those plans who are now going to be impacted by the law. But I appreciate the compromise.
Okay. All right. Thank you, Kim. Brian.
I'd like to echo that these are in no way random. I could easily say 125 is fine if it was a random assortment of prescriptions identified by a non-PBM third party, but that's not what we have here. They are strictly the most expensive prescriptions you dispense for the things that are most likely to have an inaccurate calculation. So let's not kid ourselves here and say that this is random. It is the most expensive products you're going to dispense for a carrier. They just want to have access to more of those products to audit in hopes that you made an error.
Okay, but I've heard that I can get them down to 125. So I'm hoping that's where we're going to go. Delegate Tavares.
I think that the conversation that was just had between them answered my question. So this isn't really random. If it's because in order to determine statistical viability, you need to really know how many drugs are being handled. But if it's a self-select group, I think we're gonna stick with the 125. Thank you.
Thank you. Delegate Pandari.
Yeah. By setting a maximum number of prescriptions that can be audited, I believe the pharmacy benefits manager or purchaser is less likely to overwhelm the pharmacy with audit requests or to unfairly target specific pharmacies for audit. I think the compromise number 125 sounds good.
Okay, thank you. We're going to the top of page 6. We crossed out lines 1 to 3, and that is we crossed out the fees, so we don't need to adjust the fees. We're going to page 7, and we eliminated 17 to 24 just because of the administrative challenges that would go with that. And it doesn't really help the pharmacist to know, this information. Can everybody live with the strikeout of 17 to 24? All right, not seeing any hands. Going to 26, line 26 on page 7. We added the notion of a secure portal. We know that more people are using it, and some of the carriers have the PBMs and the carriers have them available. So it is another option, but we are still requiring the phone number, which I know is important to the pharmacist. Everybody live with that?
Yeah.
Okay. And 28 to 30. We just added the secure portal again. And that 72 hours is the same. Okay. And I see Delegate Bandari, your hand is up.
No, I'm
Okay.
sorry.
Okay, Kim, your hand is up.
Thank you again, Madam. I'm sorry. Thank you again, Madam Chair. Looking at the 72 hours again with the increased volume because of the expansion of the bill, I would like to ask the committee to consider 3 business days as opposed to 72 hours. These are not, as though we're not replying in this particular instance. These are important questions, but not a medical emergent question, right? So in terms of wanting to make sure we're replying in a short time frame, not a long time frame, but also trying to make sure that it is manageable from a business perspective without having to over-resource this particular function over other more important functions that are, manning calls for other reasons. We were hoping that perhaps there could be some compromise on that time frame to 3 business days.
Okay, thank you. Zach?
I think in the interest of time, I'll say me too to Ms. Robinson.
Okay. Mike?
3 business days, please.
Okay. Can my pharmacist friends live with 3 business days? I see some nods. All right. Very good. And we're going to page 8. And we added, adding the provision of secure electronic communications. Okay. Kim, you responding to that?
So Mike will.
Okay. Mike?
So why is it really limited to the auditing entity? Or is it a broader? Is it because the PBM is providing the phone number and everything else? Why is it the auditing entity that has this obligation here?
You're right. It should probably be the PBM.
The PBM?
Well,
okay.
If I could,
yeah.
It really is sometimes, and you can say PBM or if that makes you guys happier. Often the PBM will hire an auditing company, and we're just dealing with the company. We're one is Xerox or whatever their name is now. They've changed names, but we're generally not communicating with few exceptions directly with the PBM. If you want to put PBM or, and that way you have the option if that makes it better for you. But we want to be able to submit that documentation to whoever has mandated that we do it. And I don't want to stand over a fax machine. And if the language makes sense, that's the purpose.
Mike, could you do or?
Well, I'm just looking at the prior page where the phone number and the secure portal are all related to the pharmacy benefits manager. So I was just trying to be consistent there, and the auditing entity stuck out as something that wasn't consistent.
Right, but if both things are here, then, and if we know that they are communicating with the auditing entity, then we can include it there. And it's time sensitive out to 25.
And Mike, if you want auditing entity on the other previous page instead of PBM, I don't think we have a problem with that.
Consistent with the MIA's earlier comment that the PBM is really the one that's kind of, being regulated here. And if they're using an agent called an auditing entity, they're going to have to, the PBM is going to have to make sure it gets done. That an MIA told you they don't really regulate the auditing entity. So if they fail to do what you're asking them to do here on page 8, they don't have a stake at it. So I just thought PBM.
You've got a good point. We're fine with. I think that's fine.
Okay, leave it to PBM. Okay, cool. All right. So, are there any outstanding issues? And I bet I know what Kathleen's going to say. So I'm going to go to you first. And we know that. And tell us.
I'm on it again.
So that everybody has it. Lisa's on it, but go ahead.
Yes, Lisa is on it. Thank you. Strike page on page 2, lines 1 through 8, I believe, or 5 rather. I did have a conversation this evening with Trisha Roddy from MDH regarding my concern that we be regulated by MDH in this space, not by the insurance commissioner. And so she's willing to work with us to make sure that the language is put in a section under the Health General article, and then ensuring that the language doesn't come into conflict with federal law.
Okay.
There are provisions today that come down from CMS regarding audits and the obligation of the program and the MCOs to conduct those. And I think it's something that we can work with pretty easily.
Okay. Great. Thank you. Thank you.
Thank you.
We'll get that done before Tuesday. Kim?
Yes.
Oh. You have something outstanding that you
No, I'm
need us-
sorry. Apologies.
Okay. Delegate Taveras.
No, I was just gonna say if they did want to leave PBM on the last page, if they wanted to do that, or their designee. In order to, but if everybody's fine with the current, I'll stay. I'll stay. I'll stay fine.
I think everyone's okay on the.
I'm fine then.
PBM.
Don't worry about it.
Aaliyah.
I'm ready for Tuesday.
Okay.
Would there be an opportunity for a July effective date?
I'm hearing no. Mike?
Well,
Is that
let
you?
me, because I was going to address the the effective date anyway. Here's
Okay.
the situation. We've expanded this to cover plans that have existing contracts with PBMs, auditing entities, and audits are ongoing. And those contracts require the PBMs to conduct certain auditing. So I kind of have, we typically for health plans at least have this concept that talks about, takes effect January 1 and applies to contracts entered into on or after that date. This does affect some of those existing relationships. And I'm not sure that even October 1st to me was too early for school boards and counties and others. And I think even the ERISA bill had a January 1, 2024 effective date. And this applies some of those ERISA things on audits, particularly to those plans effective October 1. So I would respectfully request that it should be January 1, and there should be some conversation about what it applies to beginning January 1.
Okay. Steve? You have thoughts about that?
I'm sorry. Okay. Firstly, regarding the MCOs, right now there is no audit regulation for them, so they have to be included in this process.
Steve,
Whether it's
We
here,
are going to.
General.
We just
They're
are
going
gonna-
to be. They're in Health General.
that's fine. I trust you.
Bill, only
And-
it'll go in Health General.
That's fine. And then in terms of the date, I would like it yesterday. What I want's not reasonable. Mike would want it in 3 years. That's not reasonable. So the 10-1, I would urge you to stick with it. This doesn't stop auditing. Audits occurred. They're going to continue to occur. They just have to be reasonable. So I would not extend. I would not make the date further. Thank you.
Kathleen?
Thank you. So this may be something to check in with MDH on, but the MCO contracts with the department are annual and they're renewed every January 1. CMS requires that any new regulations or state laws be included and updated in those contracts when they take effect. So the January 1 may make sense just from that perspective, so that it would coincide with the new contract that's issued on January 1 of 24.
Let me ask Mike, and in terms of other contracts, are they January to January? Or could they be anywhere? They could be anywhere,
They're
right?
all over the place,
They're all over.
right? So a
Right.
school system may have a July 1st to a June 30th, right? A
Right.
county may have a November 1 to an October 31, at least for the plan year, which often lines up with the beginning of a TPA's contract year or a PBM's contract year. And then it's a 3 or 4 year contract. So this will affect existing agreements, whether it starts October 1 or January 1. But what we typically do is give some lead time so that they can make those changes with their own contracts, let alone with how it affects the plan and cost and premiums and things like that.
Okay, thanks. Kim?
To Mike's point on the timing, it is a big deal for companies who don't see this coming and aren't used to an outside entity now stepping in and reforming their contracts without their expectations, because that's what you're doing, right? If they've got audit provisions that differ from this, they've now all got to be revised in from what they asked for in the contract when they gave the requirements that they put upon us for the audit. That's particularly important, I think, for your counties who are also funding it through their budgets, because to the extent it changes their pricing, it changes their budget obligations. And so I do think, it is kind to your counties to give them a little bit more lead time so that they can prepare for what all these bills are going to do to them financially, because they've got to now fund it because they're paying their own dollars for these benefits, right? So to say, can we have just a little bit more time? It's not for us, it's for the client who's got to adjust.
Okay.
And so looking at January 1 as their contract rolls, I think is really important for them, even though I know they're not, I don't think Brianna could stay, but I think it's really important for them if they're not here to say it for themselves.
Okay, thank you. Delegate Chaveras. Yep, you're on mute.
But to Kimberly's point, if we are deciding people, like budgets for the counties and localities, the state finishes in April, the counties finish in July with their budgets. So should we not give them some time for until October 2023 or 2024?
No, I think the question is it October 23 or is it January 1, 24? That's the question.
Got it. Okay.
Let me, since we're holding this over, I need to do a little more research on this. So, just to look at contract times, and when we come back on, we will let you know before we come back on Tuesday. But I'm not seeing any more hands. So I think we have almost a finished product on this one, but like I said, I want to make sure that everything is worked out, and we will, like I said, try to do quick work on this on Tuesday. I want to say thank you all for your patience, your endurance, your perseverance. I apologize to my committee for making you work so hard. And after I say that, I'll say, I will see you at 9 o'clock tomorrow. We are doing one bill tomorrow, and that's 785. So at 9 o'clock, if you have an interest in 785, we will see you then. But for now, this meeting is adjourned. Thank you all very much.
Thank you.
Thank you.
Thank you.